So this one was a shave biopsy.
Good.
I thought that there was something going on in the stratum corneum. Sorry. So there was like lamellar hyperkeratosis, and then I thought I saw kind of maybe like a dermatophyte or spaghetti meatballs in some parts. And then I think in the highest one of the cuts, there was a larger circular structure that looked non-human or foreign, and I wasn't quite sure. It seemed to be too large to be tinea or candida, but too small to be scabies or. And there was just
You're
like
talking about this kind of blackish stuff here?
No, not the black stuff. It was like a golden brown
First.
almost. Yeah, the first cut. I'm not sure if it's upside down.
Oh yeah, the first cut, and then there's like this little thing in the stratum corneum.
Well, what's the pattern of the epidermis?
It's popular.
Yeah, that's correct. Notice that it's kind of papillated or even digitated. So what's the difference like digitated and papillated?
So I think about maybe like a seborrheic keratosis or something like that.
But what do you, when you talk about the difference between like something that's digitated versus papillated?
What's the difference?
Yeah.
Digitated is usually more like finger projection.
Yeah, good. It's more kind of like spikes almost, whereas papillated is more kind of like gentle papillae, like nipple-like projection. So one looks like finger-like projection, and sort of nipple-like. And this is more digitated, and notice it's kind of got reticulated epidermal hyperplasia with overlying digitation. So yeah, this could be a seborrheic keratosis or something like that. But you were saying the cornified layer is a little bit unusual for that.
Yeah, I thought that was where I kind of noticed the majority of the changes. There isn't any parakeratosis, but there's definitely orthokeratosis.
Yeah, I agree. This is not normal cornified layer. It's thickened.
And I thought that there were little collections within it.
Yeah, there probably are some pterospora in here, right here, for example.
Yeah.
I don't see spaghetti. I just see meatballs only.
Yeah, maybe I saw the meatballs. I was trying to imagine that there might be spaghetti too, but
there is pterospora. There's a lot of that, and some people think that actually plays a role in the cause of this process. So, what was your differential?
So the differential that I wrote was tinea versus candidiasis, but maybe I can elaborate and change that a little bit now. So other
It's
things.
All right, we allow people to change their minds, so that's okay.
So maybe if you're thinking that maybe pityriasis rosea.
Well, that usually doesn't give the digitated epidermal hyperplasia, does it? That's usually more of a slight spongiotic dermatitis with mounds of perikeratosis and lymphocytes with extravasated erythrocytes. So this has definitely got something going on that's wrong with the epidermis.
For sure, yeah.
I mean, it kind of looks like a seborrheic keratosis, doesn't it?
Yeah, for sure, but the inner horn cells were.
Yeah, I mean, it'd have to be like a macular or stuccokeratosis. But what if this was present in a widespread fashion, like over the trunk?
Widespread over the trunk. Rate of pathway change.
Maybe we can show them a picture of it. Yeah, what if it looked like this?
Oh, that almost looks like
You started to say it.
Is this terraformate?
It could be that, but if you look at terraform dermatitis, it doesn't really give you the digitated epidermal hyperplasia. So this is confluent reticulated papillomatosis. So it's confluent and it's reticulated here, you see it, and it's papillomatosis when you look at it under the microscope. So this is carp, and it looks very similar to Acanthosis nigricans. It's in the family of the epidermal reticulated proliferative conditions. There's like about 4 or 5 of those. So you get Acanthosis nigricans, you get Dallan-Dago's disease, Golgi disease. There's several of those diseases that all kind of look the same histologically, and some people think that they are sometimes induced by pterospora. Go to the next slide. So these are some of the items of the difference. This was basically carp. So just notice the morphology. Kind of looks like a seb, but it's widespread, and it's not a seborrheic keratosis clinically. So that was carp. Okay. The next one, if you guys don't get this right, it's like tragic.
So we have maybe a shallow punch biopsy.
Yes.
And just looking at it from low power like this, you can see that there's parakeratosis. It looks like a lot of acanthosis.
Yeah, good.
And I think it looks like a lymphocytic infiltrate, like
Yeah,
right
that's
below.
superficial perivascular lymphocytic infiltrate as well. What about the acanthosis?
Yeah, it's very regular.
Yeah, very regular, isn't it? Very thin, elongated epidermal rhesia. They're all, you kind of draw a line around the bottom of them, so they're pretty much all about the same sort of thickness, if you will. There's parakeratosis, as you noted. What else do you see?
Maybe thinning of the suprapapillary plates. I
Is
see
it
vessels.
maybe, or is like
There is.
Yeah,
And
for
then
sure
there's,
there is.
and then the vessels go up the papillary.
Yeah, there's dilated blood vessels. There's thinning in the suprapillary plates. There's, you said there's parakeratosis. What else is up here besides just
Newts.
neutrophils?
Yeah.
What about the cornified layer? What about the granular cell layer?
I don't really see
Yeah, it's gone.
anything.
It's absent, basically. Maybe focally present. Ah, there's our superstar just showed up. Pele. So what's the diagnosis?
Psoriasis.
Psoriasis. Excellent. Good. So this is classic psoriasis. If you guys didn't get this, Dr. Mincher would have a stroke. So you better make sure you know what psoriasis is. This is classic, beautiful example of psoriasis. What am I showing here? What finding is this?
Mitotic.
Is that a normal location for mitotic figure in the epidermis?
It should be in the basal layer.
Yeah, suprabasilar mitoses. So that's a sign of psoriasis also. So if you get maybe a partially treated lesion of psoriasis, maybe they've been on a biologic, but they still have some residual disease, and somebody wants to biopsy it, and they say, well, it won't look like classic psoriasis because it doesn't have this beautiful non-treated psoriasis morphology. And if you see suprabasilar mitoses like this, it's a clue to the diagnosis. So normally it takes about 6 weeks to go from the basal cell layer all the way to be sloughed off here. In psoriasis, that's just a few days, much faster. So that's why we use things to slow down that mitotic rate. So good, this is a classic example of psoriasis. Psoriasis, you can sometimes get some spongiosis in here. Get a lot of inflammation in psoriasis. Sometimes you can get some eosinophils in psoriasis. Show a clinical photo if you'd like. So this probably is sort of what this lesion might have looked like clinically. Most people don't biopsy psoriasis when it looks like this unless they just like biopsying patients for fun. So they usually biopsy lesions that don't look like classic psoriasis. That's where we have to sort of work at making a diagnosis. Okay, the next case.
And so in this lesion, it was looked to me like it was kind of a punch biopsy of non-equal skin, possibly.
Yeah.
And so going in and looking at the epidermis, that's where I noticed some of the action to be, mostly action to be. So some of the cells.
Do you think it was an inflammatory or a neoplastic?
Neoplastic.
Yeah,
like
good.
Neoplastics. Some of the cells were atypical and irregular in the epidermis. I was looking through it. I was having a hard time deciding whether or not it was full thickness or not full thickness.
So you thought it was an atypical, did you think it was, what kind of differentiation? Do you think it's a neoplasm? Do you think it's benign or malignant?
I think malignant, kind of beginning
Okay.
stages of malignancy.
Good, excellent. I'm at early stage.
Mhm.
Excellent, very good. And what kind of differentiation?
The like the keratinocytes are just atypical. I didn't.
So you thought it was
there's,
epithelial?
epithelial, correct.
You thought it was probably squamous epithelial
Correct.
since it's keratinocytic. Okay, good. So what was your diagnosis?
The actinic Bowenoids disease. Felt like it was
So actinic, you thought it was Bowen's disease, squamous cell carcinoma in situ?
correct.
Okay, good. That's a very good idea. And I think that's reasonable if you thought that. That's excellent. So what's in the differential diagnosis of that?
So the actinic keratosis, Bowenoid actinic keratosis, or just Bowen's disease.
Anything else?
And then
It looks
Bowenoid
Bowenoid?
papulosis.
Yeah, that wouldn't be, with all this sun damage, we wouldn't
Yeah.
think, would it? That looks more like a condyloma.
Mm-hmm.
But what else can look pagetoid or Bowenoid sometimes histologically, but it's not keratinocytic?
It's like a nevus and
Melanocytic can, yeah. Melanoma in situ
can
can look like that. There's about 5 or 6 things that can give you kind of a pagetoid intraepidermal proliferative morphology that you need to know.
And then would a Spitz nevus also do that?
It can give you intraepidermal involvement, possibly, yeah. They're like a junctional Spitz's nevus. But there's a couple other things too that can give you this pattern.
Pagetoid carcinoma of the breast?
Yeah, Paget's disease, that's right. And there's 2 types of that, right? There's breast and there's mammary and extramammary. So that's in the differential. Probably wouldn't be extramammary unless they were outside without any clothes on or something for many years. That would be kind of unusual.
Yeah.
There's a couple others that you should just know about. The Langerhans cell histiocytosis, mycosis fungoides, so-called pagetoid reticulosis can do it. Merkel, sebaceous carcinoma. So there's not a ton of lesions that can give you this sort of pagetoid involvement. So this actually, because this wasn't full thickness over a broad front, we call this a Bowenoid actinic keratosis. But basically, if you were in the right category when you thought that, the most important thing is just to remember the differential diagnosis, because you wouldn't want to miss melanoma in situ here, obviously. And if you're really concerned, you do some immunoperoxidase stains if you wanted to prove that these were keratinocytes. You look at it carefully to see if there are some intercellular bridges around a lot of these cells here. So that kind of helps when you see that sort of change right there. So anyway, this was pagetoid actinic keratosis. They just look like regular AKs, so you can't really tell them histologically, clinically from the other. So like that. Okay.
Alright, so we have a punch biopsy. And so far what you can appreciate is that there's hyperkeratosis with orthokeratosis, most likely. And then there's some superficial, what appears to be like a superficial slight inflammatory infiltrate.
Yeah, it's pretty sparse.
Yeah.
What about, and you said there's hyperkeratosis and some papillation here. This is more papillomatosis,
Yeah.
opposed to digitated hyperplasia.
Yeah, and then there are a couple of things here that are kind of striking is the presence of these keratotic cells in the epidermis.
Yeah, quite a few of them.
In the epidermis, that and then the other thing is right down below in the dermis.
This area or down in this area?
No, the first one is.
The first one?
Yeah.
This area, okay.
Yeah, that has a distinct color and like this pattern of collagen or whatever that is. Is different
So
from.
this is collagen.
Yes.
Is this collagen?
I wasn't entirely sure. It looks like some. First, I thought it was like deposition, but I wasn't sure. It had some. It didn't have exactly the same.
Yeah, this is very nice contrast here. This is normal collagen. Look how pink that is.
Yeah.
What color is this stuff?
Pale pink or
It's almost kind of a grayish pink.
Yeah.
So this is like a nice, bright, hot pink, if you will.
Mm-hmm.
This might be really hot pink. This is maybe a little sort of less than regular, normal pink, and this is kind of a grayish color. Grayish pink.
Mm-hmm.
So what gives you this? It's also noticed that's kind of got these sort of small clefts surrounding it.
Yeah. So when I saw
globules.
yeah, when I saw the clefts, I thought amyloid.
Do you still think amyloid?
I am not sure about the final diagnosis on this, but that's what I thought initially when I saw the clefts.
So what else
But the
would
thing
you
is,
think of?
well, I didn't recall amyloid being so cellular.
Well, so these cells are probably some background cells, a blood vessel right there, and maybe some fibroblasts, and just kind of happen to be sitting there from
Okay.
being the dermis. So if something gets deposited, it, depending on how much of it gets deposited, it may or may not replace everything that's there. It may just kind of intercalate between some of the pre-existing things that are there to
Okay.
begin with. So
Then I will stick with amyloid.
good, I'm glad. What else were you thinking it might be, though?
So
Because the board's gonna not just have one answer for
No.
you, they're gonna try to trick you
no,
out.
the first part when I saw the epidermis first, and I saw all the dyskeratotic cells, and I started thinking on the way of like a vortidiskeratoma and things like that, but it didn't really have acantholysis. It was mostly like
Yeah, so what's the pathophysiology of amyloid in this situation here? Should we work this guy up for like multiple myeloma and do a bone marrow?
So that would be-
hematology?
that would be the nodular type.
Yeah, we wouldn't want to do it for this type, would we?
No,
No, it'd be a big expensive workup and
yeah,
all sorts of
but
stuff.
this one,
Where does this amyloid come from?
this is derived from keratinocytes.
Yeah, it's coming from these cells.
Mm-hmm.
So these cells are just degenerating, and eventually it deposits into this amorphous material. So this is amyloid that comes from the keratinocytes. So this is a different kind of amyloid than the amyloid that circulates. So this starts off, we don't know exactly what happens. Probably something happens where they get small, tiny collections of amyloid, and macular amyloid is very itchy. They scratch, and then they get this marked lichen simplex chronicus with more dyskeratotic keratinocytes, and it turns into lichen amyloidosis.
Mm-hmm.
So this is lichen amyloid, which is basically the same spectrum as macular amyloid.
Yeah.
We have a picture of it. Often occurs in the pretibial areas. Very itchy, kind of gives you this rippled pattern. It's very characteristic of that. So this is lichen amyloidosis. Good. So what else did you think of if you didn't think of amyloid?
So when I saw the dyskeratotic cells and hyperkeratosis like that, without thinking amyloid, one of the things I thought was like a BLK, benign keratosis.
But you rejected that quickly
Yes.
when you saw the pink material, right?
The
Good.
pink thing was like
Congratulations. All right, well, let's move on to this one.
Okay, so this was a shade biopsy,
Good.
and there was a sea of these, I want to say, cells in the dermis. I thought the overlying epidermis was okay.
Yeah,
I thought initially this was going to be like a lymphoma because I thought it was so dense, or like a metastatic disease or something like that. And it took me a little while to figure or think about the cells. But I did notice on high power that there were some clefts. I wasn't sure if that was just from processing or not.
yeah, this stuff is just processed.
Yeah. Okay. So when I looked closely at the cells, they kind of almost had, they were large, and they almost had two different colors within the cytoplasm, I thought, in places. They kind of had a halo almost around them.
I would agree with that.
So kind of on review, I thought that maybe these were histiocytes. I thought maybe they were replicating in areas, and yeah, they were multinucleated. And then there's some like surrounding inflammatory component also.
Yeah, there's some neutrophils, there's some eosinophils. So what was your ultimate diagnosis?
So I think I settled on the end on reticulohistid granuloma.
Yeah, I think that's reasonable. And there's two forms of that disease, right?
Yeah, well, I think they're systemic and like localized.
Yeah, there's the multicentric reticulohistiocytosis form, which is associated with what sort of problem.
So you have to work up for malignancy. Or,
Yeah, but there's one other bad thing that they get with that that's even worse than malignancy most of the time.
they, like
They get
rheuma?
a terrible arthritis.
Oh yes, you are right.
Uterine
Yeah,
arthritis.
yeah.
So yeah, they can sometimes be associated, I think, with some underlying myeloid leukemias and things like that, but I think the main thing is I think it's horrible arthritis.
Yeah.
And this might be a juvenile's anthogranuloma or an adult's anthogranuloma that's just got a lot of reticulohistiocyte-like cells in it.
I looked for Teuton cells and I didn't think
There
maybe.
weren't very many of
Oh,
those
okay.
in here, you're right. And sometimes you just don't see very many. Some people say if it's just a solitary lesion, it's probably just a variant of an XG. If there are multiple lesions, then you think about reticulohistiocytoma. It's sort of whether you're a splitter or a lumper, it doesn't really make that much difference. The main thing is just to make sure that you're not missing anything systemic. Generally, most of the time, if it's reticulohistiocytoma, they don't get that inflammatory infiltrate. That usually is more commonly seen with an XG in the inflammatory stage. What's one other item to put in the differential diagnosis of this?
Like rosacea or
Yeah, although that would have the large cells with the peripoiesis. One other thing that can look like these cells that you should just know about. It wouldn't have the EOs and the neutrophils and all that kind of stuff, but these cells can look very similar to this.
another xantho is different, like something.
No, it's not even in the xanthoma
Oh, okay.
category. Spitz's nevus.
Oh yes, okay.
Cells of the Spitz nevus can sometimes simulate that. So here's a couple of examples of this. So down the right might have been one of the guys that might have arthritis associated with it. Everyone showed so much arthritis there. Okay.
So this one I wasn't really sure. It looks like it might have just been taken off in parts.
Yeah, or when there's no epidermis at all, they either a really lousy dermatologic surgeon / biopsier, or the lesion might actually not have much of an epidermal component. So when you're seeing patients in the clinic, you do shaves, you do punches, you do excisions, and then what's one other technique that you sometimes do? Like if somebody comes in with a lesion on the scalp that you think is a cyst,
Then you kind of do like an incision and then you just take the cyst out.
you pop it out.
Mm-hmm.
That's called an enucleation biopsy. And so if we see something that we think might be enucleation like that, it's often because clinically they think it's a cyst.
Mm-hmm.
So do you think they might have thought this was a cyst clinically?
That's what I thought from looking at it.
Yeah.
That's probably a lining right there. That was
Yeah, it
the
is a
lining.
cyst, right? So it is a cyst in part. Now, not everything is a cyst. You got some other stuff going on over here, but it looks like a cyst. So clinically, they probably thought, okay, this is probably just a regular old garden variety cyst, and they enucleated it out. And guess what? It's not just a regular isthmus catagen or tricholimal cyst, is it? No. It's hard to tell what part of the body you're on, but it's certainly hair-bearing skin because you've got these large sebaceous lobules. So it might be the face. It might actually have been the scalp. So how do we approach cysts?
We look at whether it's a true cyst or based on the lining.
Yeah, good, on the lining. So what kind of lining did you see here?
I thought it might have been some sort of maybe stratified columnar or cuboidal.
There was some of that, but if you look carefully in some of the other areas, there were some little things like we see right here. High magnification. What are these little blebs that are kind of coming off the top like a lava lamp here?
Are those cilia?
You guys know what a lava lamp is?
Oh, yeah, that purple one.
So cilia they don't look like little lava lamp blebs. They look like little tiny hairs.
Mm-hmm.
So here we don't have we got lava lamp going on here. Stuff that's like being pinched off and floating out into the surface. So what kind of differentiation is that?
If it's like a gland,
What kind of gland?
glandular, apocrine.
Yes, apocrine. So we have an apocrine cyst, right?
Mm-hmm.
Okay, so what's the diagnosis?
Apocrine hydrocystoma.
Well, that's close. But what's a little different about it than that? Is that an apocrine hydrocystoma over here? Not really, is
Guessing
it?
not.
It's got these little, remember we talked about papillae earlier?
Mhm.
So it's papillated over here. It's almost got kind of a quasi-cribriform morphology. It's got this little duct-like structure over here. So it's got a cyst that's got a little bit more solid area with papillated apocrine proliferation over here. So when you put it together, you got a papillated apocrine cyst adenoma. So that's what this is. It's basically a type of apocrine cyst. It's not just an apocrine hydrocystoma because it's got this other component to it. Apocrine hydrocystoma is just a thin cyst with just pure apocrine lining. So it doesn't have all this kind of stuff to it.
I haven't learned my cyst yet. I can just
Well,
picture
you're
one
doing
with
good. You're
the
doing
name
good.
apocrine
You're
in
learning
it.
today. So that's your job is to learn. So you just learned something. So this is a papillated apocrine cyst adenoma. It's a great name for it, right? So there's a couple of other things that fall into this general category. One or two other entities that look kind of like this. That are apocrine. And they're kind of like cyst adenomas.
Like SPAP?
Yes, syringocyst adenoma papilliferum. And what's the other one?
So you have Psoriasis, Dermatopathology, and then you have
One of them looks kind of like that, except it's in the groin area. It doesn't have a lot of connection to the epidermis.
yes, exactly. SPAP is connected, and then Hydra.
Yeah, hydradenoma papilla.
Causative.
Good.
He wasn't
Good.
at home.
So that's what it might have looked like clinically. They're often kind of bluish, so they're often thought to be maybe blue nevi, things like that. And then you can see what it looks like. They didn't enucleate that; they actually excised that one on the right. But sometimes you'll just nick over this thing and it pops right out. Okay. What do we have here?
So here we have a shade biopsy, like non-equal skin. So it looked like had going on to the dermis. That's where a lot of action was. We see some kind of from far view here. We see it looks like pigment in the
Oh,
dermis.
this isn't a far view. This is more of a far view.
I got bad eyesight.
No, you do not. You got great eyesight. Absolutely not.
From this view, from the mid bird's eye view, we see some pigment in the, looks like, appears to be from this view, pigment in the dermis.
Yeah. So did you think this was an inflammatory or a neoplastic process?
About neoplastic.
Good. Perfect. Neoplastic.
Mhm.
Benign or malignant?
I was having a little bit of difficulty with that.
No, not at all. Not at all. So
Was
let's apply
benign
the
then?
criteria.
Was
Here,
benign.
look at this bird's eye view here. This is like an eagle's view. How big is this thing?
So it's not very big.
No.
It's pretty small.
Tiny.
Yeah.
Teensy tiny. Probably a millimeter.
Mm-hmm.
2 at the most, probably. Very, very small lesion. So when something's small, what is it generally benign or malignant?
Generally benign.
Yeah, usually
Yeah.
benign.
So I was thinking it's one more benign.
Yeah, good. I'm glad you were. So what else? So it's small. Is it symmetrical?
Yes.
Yeah, it's very symmetrical. Is it well circumscribed?
Yes.
Yeah. So based on that, it's almost certainly going to be benign.
Correct.
It doesn't have to be. There are exceptions to every rule. So I don't want you to think that everything that's small, symmetrical, well circumscribed is benign. What's one quick example of something that can be small, symmetrical, well circumscribed and is malignant?
Untitled malignant.
No, because that's not small and it's not well circumscribed at all. That's broad, that's huge. But it's in the family of melanocytic lesions.
MIS.
No, that's the same thing, by the way,
Um.
in general. So
Bonoid papulosis could be. That's not really-
Not usually.
Like well circumscribed, as in
Small, well symmetrical, well circumscribed. It looks benign by architecture, but it's actually malignant. Metastatic melanoma.
oh,
A small little papule of metastatic melanoma
Okay.
can be pseudo benign because that breaks the rule. So I don't want you to think everything that's small, symmetrical, well circumscribed is benign. You know, there's a metastatic blue nevus-like melanoma that can look small, well circumscribed. So, you know, we use these things as guidelines, but they're not like the Ten Commandments. Okay, but back to this one. This one does obey the rules. So this is benign.
Just dermal nevus.
A nevus, good, excellent. So if it's melanocytic and it's benign, it's a nevus. So the next step is just like, you know, food. You have to then be a little bit more of a gourmet. So we know it's melanocytic. So what kind of a nevus is it?
Considering I saw the action of the dermis, a dermal nevus.
Okay, we're into
Intradermal
the steakhouse restaurant now, so we need to decide a little more further here. Are we going to talk about a ribeye or a fillet? So it is a intradermal nevus of some sort. Is there anything more specific you can say?
Spindle cell?
I'm sorry?
A spindle cell?
These are not truly spindle cells. They're kind of elongated with these fine little tentacles that kind of stick out. What do we call that? You may not know. Anybody know?
like the dendrites.
Dendritic, excellent. Dendritic, that's one type of melanocyte. Small round, large round, pagetoid balloon, oval spindle, multinucleated dendritic. So these are not dendritic here, though, are they? These are more small round. So what do we have?
Dendritic.
We've got a type of what type of nevus gives you these dendritic melanocytes like this in the dermis? Don't overthink it.
Dendritic nevus? Dendritic melanocytic nevus?
And then, yeah, but what do we call that usually? Clinically and histologically for that. A blue nevus. So we have a blue nevus, and then we have more of a common intradermal nevus component. So what do we call that?
Intradermal blue nevus?
A combined nevus. Combined blue nevus. So that's what this is. This is a combined blue that can give you, they just look like a blue nevus when you look at them clinically, so the slides don't really matter much. But you can get a lot of different types of combined nevi. Combined Spitz's nevus and blue nevus. The blue nevus with pagetoid cells. There's the so-called new BAP1 nevi that we see. Those can be kind of combined nevi. So this is a combined blue nevus. Totally benign. Just kind of a histologic variant, if you will. Okay, very good.
Alright, so the flash biopsy,
Yes.
and from this power you can see that there is some sort of proliferation.
How old is this patient?
How old?
Yeah.
Probably would say youngish.
Yeah, good. Why youngish?
There's like the collagen. Well, first of all, I don't see any solar elastosis.
Excellent. Very good. If you live in Texas and you've been around for more than a few years, you're probably going to have some solar elastosis unless you're biopsying something in the groin or something where there's no sun exposure at all. But there's a couple other clues. It's a punch biopsy, and it's pretty thin punch, and it goes way down to the bottom of the fat. So the whole skin is fairly thin. So it's a young patient. And then also notice these hair follicles are small and miniaturized. This isn't an alopecia. And the sweat glands are kind of small. So everything is small.
Yeah.
It's a baby or a kiddo. So it's a youngster. So that's good. So what did you think we saw in this youngster?
So these structures that are in the dermis that have like these spaces, they look basophilic cells. That have this sort
You
of
mean this area?
all these. They look like kind of like glandular
glandular. Okay, well, let's go to higher magnification.
And
These
then,
are glands right
yeah.
up here for sure.
yeah, and then those spaces look like more like blood vessels.
Blood vessels.
Yeah.
Good. Excellent. And notice how they're kind of arranged in all these little kind of tufts in a way. They're kind of these little glomeruloid sort of aggregations. Okay.
And then, yeah, so basically this fits, well, yeah, this fits with the glomeruloid hemangioma.
Yeah, it's got a little
Kind of.
glomeruloid morphology, but good. It's an hemangioma, or it's one of the vascular proliferative conditions, probably of childhood.
Mm-hmm.
And sometimes, you know, I can't be 100% sure just looking at this here, what exactly is going on. I mean, it doesn't look like poems. It doesn't have vascular proteins that have coagulated and stuff's occurring secondarily. Usually a tufted hemangioma occurs kind of more diffusely in the upper part of the dermis. So this is basically a variant of the hemangioma, and these are the kind of lesions that we might want to do a group 1 stain on or something like that. It doesn't look like Kaposi's, it doesn't look like angiosarcoma, anything like that. It's fairly deep.
Mm-hmm.
It's down in the subcutaneous fat. So it's even theoretically possible it could be the surface of a vascular malformation, but it's definitely in the family of the hemangioma, vascular malformation sort of spectrum, if you will. So histologically, it look very, very similar.
But in the glomerular hemangioma, you would see like those structures like look glomeruloid, but you don't really need to see any other complication of poems. You just can find it like.
Yeah, exactly. I mean, most of the time you do see some of that if you see it in forms.
Mhm.
I'll give a photo here, so it just shows an example of one of them. Okay,
Okay.
beautiful example.
So this is a deep punch biopsy. And there is a structure in the dermis, deep in the dermis. It looks cyst-like, and there seems to be a true lining.
Is it really? It's got a lot of other stuff. It's got some
Yeah.
clefts in here too, right?
It does. Yeah. So there are alterations in the different types of cells within the structure. I thought that maybe some of them looked a little, like when I looked a little closer, I thought that some of them almost had a ghost-like appearance, but I didn't see any calcium or deposits or anything like that. So I thought about.
So you think this is a neoplasm?
Yes.
Okay, benign or malignant?
I think it benign.
Okay,
I
very,
don't-
very circumscribed, right?
Mhm, yeah.
Very symmetrical.
Yes.
Okay, so it's, again, it's in the subcutaneous fat, but it's really not huge. You got the whole thing out with a punch.
Mm-hmm.
So it's probably like a little small dermal base nodule,
Mm-hmm.
maybe even a subcutaneous nodule. It's really, really deep. So clinically, this probably would have been a very low dome process. Probably would have had to feel this.
Yeah.
Okay. So then the question is differentiation. So it's benign. So now it's well, what kind of differentiation are we looking at?
Okay. So I may have been a little off with my differentials here. So, I think there's a lot of I'm kind of. It's so deep, but I initially when I saw it just from on the higher power, I was thinking maybe like Pyler differential, but it's super deep, so I'm not sure if that would be an option.
It's got several different areas.
Yeah.
What about if we just look right here in this area?
Okay. So there's a lot of red cells, a lot of vasculature there, and the cells look
So if you
almost
wanted
spindle
to,
in places.
there is a spindle cell component. Good. Spindle cell, and it's got a purplish color to it, doesn't it?
Yes.
But what about this area? If you just took and just looked at this area alone, what would you say about this area? What kind of differentiation are we dealing with here?
Well, there's a lot of red cells. Wait, hang on.
We
Sorry.
got vascular
Yeah.
spaces.
Vascular. So when I think about spindle cells, I think about smooth muscle maybe. Because
Good.
of the
That's
red
one
cells.
thing.
So it could be
This
like,
part
Mhm.
is vascular.
yeah.
So there's a vascular component to this, and that actually goes along with this lesion. And then notice here, here's kind of a large blood vessel with a thick wall It's probably like an arterial kind of wall
Mhm.
with smooth muscle, or there's another type of cell that's similar to smooth muscle. What is another type of cell that's similar? And you can see it kind of blends imperceptibly into this component.
So skeletal muscle, but it wouldn't be sphenoid, I don't think. The other things I think about are fibroblasts when I think about
Yeah,
the spindles.
fibroblast. So what type of fibroblast is kind of like a hybrid between a garden variety fibroblast and a smooth muscle cell?
Um, hmm. Um,
Mayo.
Myofibroblast.
Myofibroblast. Wonderful.
Okay.
So if you just look at this,
Yeah.
it kind of looks like muscle, doesn't it?
Yeah, it does. Yeah.
Yeah. And but if you look at this other stuff, it really doesn't look much like muscle. It looks more like fibroblast. So what's the diagnosis?
Myofibroma.
Myofibroma. Wonderful. Now what's this component? That doesn't look like myofibroma.
No, it doesn't.
No.
It doesn't at all. I mean, the cells here look a little different from the others. They're more rounded.
They are. They're kind of round.
It doesn't look like inflammatory infiltrate.
No, it's not.
Um,
This is a more difficult one for dermatologists because they're not familiar with this entity.
I mean, I think that just popping to my head is like endometriosis, those kinds of things, but that's smooth muscle and vasculature. I don't know if it's like becoming pleomorphic. I know we said it was benign earlier.
Well, there's a thing called an hemangiopericytoma. And
Okay.
these lesions often have a hemangiopericytoma, myopericytoma component at the periphery, like you see here. And then they've got the myofibroma over here. So it's the same lesion, it just has
Yeah.
features that kind of look like a hemangiopericytoma in some areas, and then the more myofibroma-like areas over here. Beautiful, gorgeous, fantastic example of this.
So how do you finally call it?
Myofibroma.
Okay.
Myofibroma.
So you wouldn't call this hemangiopericytoma?
You can say there's also a pericytoma-like component at the periphery, but basically it's
Okay.
myofibroma. Sometimes say myofibroma / myopericytoma, but this is
I
a
think
gorgeous example of it.
I think in the book there's a picture very similar to this
I
with
hope
the
so.
with the Mayo
We hope that they have.
with the little like the blue.
So what
Veil.
settings do we see this entity in? There's two settings.
Oh, myofibromas.
It can be seen as a solitary lesion. They're often seen in kids, or they can be multiple. And they're benign lesions, but they can get into trouble when they occur kind of in funny locations, like that eye. That wouldn't be a good place to get one of these, because they can get amblyopia and all sorts of bad stuff. So you don't want that. If they occur in difficult areas of the body, that can be a problem also.
Is it associated with any syndrome?
I don't believe it's associated with the syndrome. But
It's a chance, but-
okay. We've already had
Super
one of
so
this
cute.
today.
So we have a punch biopsy.
Yes.
And just looking at the
Does
epidermis,
this remind you of anything we've seen so far today?
maybe the carp.
Yeah. So it's the same type of process, isn't it? It's an epidermal mostly lesion. So instantly you go to the same differential, right?
Mm-hmm.
So you kind of need clinical here. And notice this one isn't as digitated as the other one. It's a little bit more gentle papillomatous than the other
Mhm.
one. Doesn't have the very thick cornified layer that the carp had. Doesn't really have any pityrosprum that, well, it might have some in here, but it's not really caused by the pityrosprum like the other one is. So what do you think about in that list that you had before that can also give you epidermal mostly proliferative change like this?
So I was thinking about just when I initially looked at this seborrheic keratosis.
Right. How old is this patient?
This patient.
They're not too terribly old
No,
either,
I don't
are
really
they?
see much.
Most people that get
psoriasis.
sebs get them on sun damaged skin, so
Could
this
be acanthosis nigricans.
that would be in the differential. What if we told you, show them the picture? It would look like this. What would you call it?
Epidermal nevus.
Yeah, this is an epidermal nevus. Epidermal nevus. So epidermal nevi, there can be a lot of different histologic patterns of epidermal nevus. This is one pattern that kind of gives you this papillomatous epidermal mostly proliferation. Obviously, if there were a lot of sebaceous lobules up here, they're connecting to the epidermis, what would we call that?
They're more sebaceous.
What's that type of epidermal / connective tissue nevus? You know, when there's a lot of sebaceous lobules, this might actually be that in just an abortive form.
Neosebaceous?
Yeah, nevus sebaceous. What if we saw epidermolytic hyperkeratosis?
Could be EHK or
Yeah, it can be like one of the
Or-
systematized epidermal nevi, this Haloposemens or something like that. What if we saw acantholytic dyskeratosis?
Already.
Well, it wouldn't be a warty dyskeratoma if it's in the pattern of an epidermal nevus.
In the nevus with
Linear dariates.
Okay, yeah.
You see what that? What if we saw features that look like psoriasis? Can that be epidermal nevus? Of course it can be. So, you know, you can get like Ilven also. So there are a lot of different histologic patterns of epidermal nevus. Okay, this one is very nice. Some of these we could show at ASDP also.
So here, punch biopsy, it's like a non-equal skin. So going down and look in the
I mean, it's inflammatory or neoplastic?
inflammatory.
Good. What's the pattern?
Spongiotic.
Well, let's look at that a little bit higher magnification. There's really no spongiotic microvesicles here, right?
Mm-hmm.
We have color changes.
Mm-hmm.
You know, when I was actually before I was a resident, Dr. Ackerman actually used to take his fellows and residents to the art museum. There's a nice art museum in New York, you know, New York Metropolitan. He said, let's just look at colors in paintings. It's a good practice to do because you can just see the main change here is color alteration. What do we have here?
A pallor.
Yeah, pallor. Good. We got normal, maybe a little slight acanthosis here, but this is more blue, purple, and this is pale and white. So why do you get pallor? And notice where the pallor is located.
In the superficial epidermis.
Yeah, it's at the top.
Mm-hmm.
It's not at the bottom. It's at the top.
Mm-hmm.
Okay, so what diseases give you, what's causing this pallor?
Stasis. Like edema.
Edema. And where is the edema?
So I'll start there in the superficial epidermis, but also down in these going
Well,
to
let's
the
focus
epidermis.
just on the epidermal edema. Where is the edema located? Inside the cells or
intracellular,
between
correct.
the cells?
Intracellular.
And then what's that called? Do you have kids yet?
No.
You have probably nieces or nephews though, right?
No.
No? Okay, well just remember when you were a kid, when you went to the fair or the park, what did your mom buy you so you keep quiet and you wouldn't scream all the time? So
Popsicles.
yeah, possibly no. What if she gave you one of the things you kind of held in your hand and went in the air?
A little balloon.
Ballooning, yes, ballooning. These are like little balloons in the epidermis here. So it's ballooning intraepidermal alteration.
Mm-hmm.
So what diseases give you ballooning, pallor, slight psoriasis hyperplasia of the epidermis? And we have a picture of what it looks like here.
Well,
I'll show you.
you can get that in nutritional deficiency.
Yeah, look at that. That's what it is right there, that photograph. So the nutritional deficiencies is a fantastic example of that here. And the ballooning is at the top.
Mm-hmm.
So there's only about one other thing that will do this. What's one thing in the differential? Not easy, but there's just one other thing really that can kind of do it.
Sunburn.
No, that gives you dyskeratotic keratinocytes. Anybody know?
No.
Irritant dermatitis sometimes. If you like apply gasoline or something like that, sometimes you can get like factitial. Sometimes you can get it up there. But this is pretty much almost pathognomonic. So which disease is that on the left? Also the right too, but especially on the left there.
Is that like an acquired epidermatitis?
What's another name for that?
Zinc deficiency. I'm not sure
But look at the clinical. It's what part of the body?
Feet.
Oh,
It's acral,
Yes.
or necrolytic acral
Necrolytic
area
acral.
associated with hepatitis, right? They all look the same under the microscope. So it's mainly just a clinico-pathologic correlation.
Alright, this is another punch.
Good.
And the striking on lower power is the lichenoid infiltrate.
Now, is it really truly lichenoid?
Well,
See, people kind of say that, but it's not really lichenoid, is it? Because it's not really obscuring the dermatophysical junction.
okay,
It's more kind of band-like.
okay. I didn't know that particular.
And it's also got some other stuff going on here, too.
Yeah, well, there's some like epidermotropism.
A little bit. There's
Um,
also, what's this change? So we just had ballooning. What's this change?
spongiosis.
Spongiosis. What about the cornified layer?
There's slight areas with parakeratosis
Yeah. Anything else?
and is that I'm not sure if I'm seeing some sort of life forms in the
Life forms.
Yes.
What kind of life forms?
The
Like
life-
alien
looks-
life forms or
fortunately it looks like terrestrial fungi.
terrestrial fungi? Good. So what's the diagnosis?
Yeah.
Tinea. Very, very good. Now, why is it not candidiasis?
The shape would be different basically.
Okay, that's one thing.
Yeah.
Another thing is tinea likes the cornified layer, candida likes the epithelium. So candida will grow down at 90-degree angles like this and getting into the epithelium, trying to drill for oil. This stuff likes to sit up here in the cornified layer. It's perfectly happy munching on the stratum corneum, producing little holes from carbon dioxide that it manufactures. So this is tinea. So did you think that when you looked at it yourself, or did you just let me show you the alien life forms?
No. I thought it was tinea. I didn't stop
Good.
to think if
Perfect.
it was
Tinea
candida
give you
or
lots of different patterns. So spongiatic dermatitis, the band-like infiltrate, almost a lichenoid pattern like you
Yeah.
noticed. It's got some eosinophils in it.
Yeah.
You can get granulomatous process. You can get follicular involvement with tinea. So lots of different patterns of tinea capitis, tinea corporis. What's the most common causative organism?
I think the most common for it's T. rubrum.
T. rubrum. Good. Okay, who wants to give this one a quick go?
So this is a punch biopsy. I thought that there was superficial and deep lymphohistiocytic infiltrate. I thought that
Was
there.
everything lymphohistiocytic?
No.
No, good answer. What other kind of cell was in here?
EOs.
Okay, there were some EOs, and what else?
Let me look. Red cells. Something else. Oh, no, nits.
Neutrophils.
Yes.
Neutrophils. And where are they located?
So they're very superficial, kind of almost interface, but
They're in the dermal papillae.
Papillae.
The tips of the dermal papillae here and in the dermal papillae.
and it looks like there's little surrounding kind of spongiotic type changes. Not quite vacuolar interface, but vacuous.
Yeah, there's maybe a tiny bit of involvement. There's really not too much epidermal involvement yet. So what's the differential diagnosis when you see neutrophils within the dermal papillae like that?
Dermatitis herpetiformis.
Yeah, dermatitis pediformis. It's kind of an unusual pattern because it's got this deep inflammation also. That's relatively uncommon for DH.
Yeah.
So it's kind of a little bit of a confusing picture, but this was dermatitis herpetiformis in this case. Obviously, there's a long differential diagnosis of other things that could be neutrophils. So we've got a picture of that here. This is what DH look like. But bullous lupus, linear IgA bullous dermatitis, there's a number of things. When you see these nice collections like this, really pretty good for DH. So you'd obviously want to do immunofluorescence here to confirm that, right? Okay. This next one is very good because, again, it's a pattern diagnosis.
This one is a punch biopsy,
Good.
and just looking at it, you can see that there's
What
some
kind of
sort
cells are these?
of lymphocytes.
But they're not as small and as black and as dark as classic lymphocytes like we saw in the tinny a minute ago, are they?
No.
These are abnormal. They have more cytoplasm. You can see that at low power.
Mm-hmm.
And is the epidermis involved?
No. And there's like a Gren zone.
There's a Gren zone. Good. And notice you got this sort of almost diffuse infiltrate at the top. And then what kind of pattern do we have down here?
It's kind of like interstitial.
Yes. Interstitial. Good. So we got an interstitial mostly pattern down here with probably the same thing. It's just there's so many cells they finally form this nodular almost kind of appearance, more diffuse appearance superficially. And then as we go to further magnification, these don't look like classic normal lymphocytes, do they?
No.
No. They're way too big. They got way too much cytoplasm. And they've got some cells that are in mitosis right there, over here. So what's the diagnosis?
Like a lymphoma or leukemia.
Good. And which of those two do you favor?
When it's in the tissue, I think of lymphoma.
What about when you get the interstitial, mostly splayed starburst pattern like this?
So I guess that's leukemia.
That's far more common with leukemia. Good. So this is leukemia cutis, when you see this pattern. I think we have a picture of that. Can you tell which is the most common form of leukemia cutis? Those aren't really great pictures of leukemia cutis. Those are like some granulocytic sarcomas. We should have a more widespread process. What's the most common leukemia that involves the skin?
The monoblast. Okay.
Yeah, like the myelomonocytic leukemias, AMML. That really tends to involve the skin a lot. The myelomonocytic form is the most common type that involves the skin.
It was interesting.
Last one.
And so here we I don't see punch biopsy of non-equal skin. I do punch biopsy here.
Yeah, do you think it was inflammatory or neoplastic?
Inflammatory.
Inflammatory.
Mhm.
Okay, what pattern?
So,
Are these inflammatory cells?
this no, they look more like fibroblasts.
Ah. We'll shift gears, maybe to the neoplastic process. There are some inflammatory cells mixed in here, though, interestingly enough. What cell is that right there?
That looks like a fibroblast. Or is that a...
Try again.
Oh, those are, those mast cells?
Yes,
Yeah, the
they look
fried
like
eggs.
fried eggs,
Yeah.
mast cells. Excellent. So lots of mast cells in here. We see mast cells anytime there's a lot of mucin.
Mhm.
And there is quite a bit of mucin in here, isn't there?
Yes.
And then you've got these other cells that do look kind of spindly in a way. They're kind of blunt, a little bit pleomorphic.
Those look like the fibroblasts.
Well, they could be fibroblasts, but now they're down in here in the subcutaneous fat. And what's this part? So this is a fat with these cells that are kind of spindly and blunt, cigar-shaped with mucin and with mast
Myofibroblasts?
cells. Probably not myofibroblasts. What kind of sort of spindle-like cells that are somewhat blunted like this go along with the subcutaneous fat? They're in the lipocyte family.
Yeah.
They're little cells that are like precursors of lipocytes. So anybody know what this diagnosis is? It's a soft tissue tumor. It's a variant of a spindle cell lipoma. So this is a spindle cell lipoma that's involving the fat as well as the dermis.
I would have never guessed that.
Yeah. I was focused
We don't
on
guess. We apply criteria.
Yeah,
We
but
never guess anything.
I remember having seen the spindle cell lipoma, and I was like, yeah, that's not it.
It's a little different.
Yes.
So it's kind of got a mixoid component to it. And so this is a variant of a spindle cell lipoma.